just back from Avicanna's sixth Medical Symposium in Toronto last week, where I had the chance to present on something I've been working on for the better part of a decade now, and that is reducing antipsychotic or neuroleptic use in long-term care for those residents living with dementia, and specifically those behavioral psychological symptoms of dementia, the calling out, the agitation, physically responsive behaviors, verbally responsive behaviors, and the harms of antipsychotics in that population, or again, those neuroleptics, have certainly been well established in the literature for a long time. And the biggest one, of course, it's on every monograph with those medications, is the black box warning for increased mortality risk, not to mention increased stroke risk, fall risk, worsening cognition, etc. The harder question, the one I think the field is actually starting to make ground on, is what we use instead. And that's certainly what I spoke about at the symposium. What do we use in place of antipsychotics? Something with less side effects, better tolerated. And what we do is structured low and slow cannabinoid titration, usually a balanced formulation starting at 2 milligrams of THC and CBD. And of course, multi-source monitoring, DOS tracking. But we take those doses from 2 to 4 to 6 to 8 milligrams. And what I'm seeing in my practice, and certainly what the early real world evidence is starting to back up, is genuine improvement in agitation, aggression, and the other behavioral psychological symptoms of dementia, with enough room created to actually de-prescribe antipsychotics in the right residents. So what we do is we titrate them up on their THC CBD formulations, observe the improvement in the behaviors, again with objective measures like DOS tracking, and then at that point we reduce the antipsychotics slowly. So the bigger thing that I want to say publicly, though, is thank you, of course. Thank you to Avicanna for the convening, and more than that, to the academics, the researchers, the clinicians, and industry partners who were in that room together. And that doesn't often happen when you get that collection of people together in the same room anymore, with limitations on funding and everyone's time. So it really doesn't happen enough. And having institutions like UHN there, University of Toronto, and other academic centers in the same conversation as practicing long-term care clinicians like myself, cannabinoid physicians, and the industry side, is how this field really gets better designed studies, better funded studies, and ultimately better care.